So our next part of the afternoon is going to be a new format involving a dialogue between one of our own mental health clinicians, Patricia Cosg, who is working at the early psychosis program, and with a gentleman here, Peter C., who is a professional engineer. And you'll see some of his biography in the program. He also has a lot of experience, but from a family perspective of working with mental health and addiction issues. So they're going to embark on a dialogue together about their experience around mental health and emergency services. So I'm going to give you the podium, and we'll take it from there.
I feel like I've opened the door to my office, and look who we have, Peter. We're sitting down for this one. I can't ensure your confidentiality, though, so I thank you very much for agreeing to share your experience with the ER mental health. We have about a half an hour where Peter will share his experience, beginning with what brought him to the ER, what was good about his experience, what may not have been so good, and what his recommendations might be. And because we only have that short period of time, I will let Peter do most of the talking. I'm just going to keep him on track in case he gets off, which I doubt it. So thank you again, Peter. So why don't you just begin by letting us know how you ended up.
It's my pleasure to be here. Can everybody hear? Okay, Patricia, she mentioned confidentiality, and it's completely overrated. It's an impediment to a loved one trying to help someone. I'll even say it's a convenient cloak to not engage. Anyway, I have quite a long history with family mental health issues, over 30 years, I guess. But I'm going to concentrate on my kids in the emergency department. So how many here have had to call an ambulance to have their loved one taken to the emergency for an overdose? Okay. And how many have taken them to the, well, I won't call it the emergency, not the triage, the inpatients for mental health issue? Okay. Anyway, my son was at his mother's house, and his 16-year-old sister found him on the basement floor, comatose, I guess. First inkling was he's dead, and so they called the ambulance, and they got on the phone to me, and his mother suffers with panic attacks and anxiety, so he's dead. I said, so I had some first aid treatment, so I walked her through getting a pulse, checking the breathing, and flip him over, get him off his back. And eventually the ambulance came. So I decided I had to, no one went with them in the ambulance because they weren't capable or weren't up for it. So I met him at the hospital. And I introduced myself, and I waited for, I don't know, 3/4 of an hour. And finally, a doctor came out, or a nurse, and said, "We need your help." I said, "Really?" And so apparently, when I got to the room, there was 3 security people there, probably 3 doctors and several nurses. And now this is a kid that's quite loving and not a violent individual. So I got around to the side of the bed, and he was just coming out of it, or he'd been out of it for a while, but he was in an agitated state, and he looked at me and he says, "You're dead too?" And I said, "No, I'm not dead." "Well, I'm dead." "No, you're not dead." And we had this little conversation in his bizarre way, and no one could calm him down, but I just took his hand, and I was able to, eye to eye, get him brought down and leveled off. And it took me a long time to convince him he wasn't dead, and I wasn't dead either. So anyway, it was quite an experience, because he eventually started coming out of this overdose. And then the questions start, what were you on? So eventually the nurse said, he's on Special K. Well, you can imagine my first thought of Special K. Special K? That's cereal. So that was my first introduction to what I guess is a serious drug in the sense of, it's a horse tranquilizer, right? So I knew he had been dabbling with alcohol and ecstasy and a few of the other things, cannabis, but certainly not to that level. So when we left, and we were only there, I'm going to say we were there an hour and a half, and I had to walk him out. And what struck me later was the fact that there was no follow-up. See you later. I think there was a comment, Connor, go get some help so we don't have to see you here again. And I sort of thought to myself after, that's interesting. If he was here all by himself, what would have happened? I happened to be there, and I'd had some training, so I wasn't mad or upset or anything. We just went off and tried to learn our thing. So that was my first incident. The second one was he got himself to the emergency department, unbeknownst to me, and I got a call and found him over in Dartmouth. And he had taken a topical ointment like it was toothpaste. And because it had ketamine in it, he needed to have that ketamine. So anyway, I went over and got him, and the nurse, he was good there, and the nurse said, Connor, you really should get into pharmacy because you know so much about drugs and all the other, he's really has done a lot of reading on the chemical stuff. So the second time, I have to skip ahead because this happened about 4 years ago, but then he decided that chemicals wasn't his thing. Maybe it's a little too dangerous. And overnight, he was going to school and had to quit, but overnight he became an alcoholic. And it was like that fast. He left drugs and was drunk all day long, all night. For 6 months until I finally said, you're out, gone. And we got him, we started going to the addiction center. We got him into the detox center. So again, he did the program, and I went over, and I was expecting some transfer. And it was, open the door, see you later, Connor, good luck. Completely unprepared for what to expect when I get this kid home, or this young adult. So at the same time, I'm learning. I'm down at the addiction center trying to learn stuff. So the next time, life went on. He got sort of sorted out, but then he became very agitated and he becomes extremely paranoid is what happened. And it escalated to the point that he was in a very acute state one night, and I'm going to say he was completely out of his mind. Paranoia, the people were coming after him, the whole works. So it took him to the emergency department. Now, this was inpatient. It wasn't through the ambulance. And so the first session was an hour and a half, or we were there. We waited, and everybody has to wait. I understand that. But we waited for, I'm going to say 3 hours, with him in a highly agitated state and me holding his hand trying to stay calm. Now, I'd had training. This wasn't new to me, so I can't imagine what a parent would be like with an individual like that. And there was no help. Nobody came out, so eventually his name got called. So he went in, and I can only describe this room as the box. Has anybody been in the box? Well, I wouldn't put a dog in the box, a rabid dog. And after 3 hours, we waited for 3 hours. He's in the room for probably another 2 hours before I get called in. And it only happened a nurse that knew the family name came out. So eventually, I go into the box. Now, the box might be it's a room, 7 feet wide, maybe, 8, maybe 10 or 12, 2 chairs, maybe 3. They're chained to the floor. There's a couple little windows, camera, very high ceilings. So I spent an hour in there with him, and I started getting agitated. I started getting paranoid because it's an extremely, extremely uncomfortable room. Now, don't get me wrong, everybody that's helped us has been tremendous. I can't say enough. But that facility is disgusting. That room. Now, I understand it's made probably for the worst case scenario where you have a violent offender in there. But I was with him, and and he had already calmed down a bit. But he was left in there for an extended period of time. I suppose they were watching him. And if I hadn't have been there, he would have left. And afterwards, he said I probably would have left and killed myself. So I went in there, and I found the room very uncomfortable. And I can't imagine that that room exists in our system for someone that is so mentally agitated and scared, because he was scared to death. He was scared to death at the emergency room when he came out as well. So anyway, the good thing that came out of it, there was some good, we had some good help. And within 3 days, we got him into the psychosis department. And I was really happy about that. That was a quick turnaround, because they didn't have a bed at the inn that night. Because we both were asked, he wanted to go into a bed, I wanted him in a bed. And so there's no observation beds at the hospital that we know of. I guess there's an observation box. I didn't know there's a short stay program, which would have been ideal, but it wasn't available, or I don't remember anybody saying anything to us, because really as a parent, he needed to be put someplace and observed, because he's gone from addictions now to psychosis. And I was trained for addictions, but I'm completely untrained for this other animal. So what we found out through some great treatment at the psychosis department is his drinking, in hindsight, was masking psychosis. So all this stuff was masking mental health issues. And, he'd had anxiety, he had some depression, he had ADHD, and he's told me his gateway drug was Adderall with his friends. So I've been on a learning curve, pretty heavy duty with my son. And so what's come out of it for me in his getting better is the importance of family support. And I'm talking about positive family support. And the fact that he's of an age now that in some cases, and I'm an easy one, there's some parents out there that are really, really struggling. Their kids are on the street, mental health, addictions, whatever it is, and this confidentiality thing keeps them from helping them. They don't even know where their kids are. People aren't allowed to say where they are or where they've been treated. And it has been an impediment for our family as well. But I also think that families, perhaps 95%, I don't know what the number is, they start off as a negative influence to help someone because they're not skilled, they don't have the knowledge. And as practitioners, if you can engage the family and try to help them and offer the services, where to go, I did a lot of digging to find out. It was just by accident where I found places. So for myself, I've been at the addiction center every Monday night for 2 years in a group. I haven't fixed my son, but it has helped me fix myself in order to help him get better. So I learned a whole whack of skills that I never had when I went in there. And obviously I was not a positive influence in his earlier struggles, because we would get in physical altercations and typical nagging you do with a kid that's struggling. So then in the psychosis department, I got in with Patricia here in her program, which is, these are tremendous lifesavers, family lifesavers. And I can't say enough about the help our family has received. And in turn, I've seen the improvement in my son. So there's a lot of benefits to it. So there hasn't been much talk here today about family support except for Sue. I think it's a critical part of someone's health especially in teenagers and adolescents and young adults. That component, it's all part of the big picture. It's a collaboration. Of course, you have to have a patient that is somewhat willing as well, and that's been a struggle with our son. However, I've been persistent and just there, learning my skills, doing my part through a lot of great help, and he's responding better. And I have to say, if I hadn't got that help here from Addictions and Patricia and help for our family, he might be one of the ones that aren't around right now. So I don't know how much I can say to
I just wanted to take you back, Peter, to when you were in the emergency department, and you had shared with me earlier more about when you were waiting and you had a nurse come up to you because she recognized your name, and I think you were saying that she did an extraordinary amount of work with you. Can you speak to that?
Actually, it was a male nurse. Just by luck, it was a nurse that's a neighbor to Connor's or my son's mother. He came out and he was tremendous, and gave me the rundown. He's okay. He's being watched, and eventually you're going to get called in. And then we were both individually interviewed together. But again, I get back to everybody here and everybody we've run across has just been so tremendous to work with. All very professional. But there is always that little room for improvement. And I sometimes think there's some silos going on between emergency and maybe the other side, even between addictions and mental health. And I've experienced some of that, and I understand it's starting to get changed. But there's certainly room for improvement, and don't be scared to engage. Certainly engage the family. They need help. They need to be trained. I've been training longer than Connor has now. So.
Working with families is always such a great pleasure, because what Peter is sharing now is a condensed version of hours and hours and hours of conversation in my closed office, and when I was asked to. If I knew a family member that would be able to speak to the mental health emergency, some of the reasons I chose Peter was because of all the work that he does within himself to become as healthy as he can be, because the more healthy our family members are, the more able they are to be able to help the person living with mental illness. So to have a family worker in the ER, like I not myself personally, but I see the need for having a family worker in the ER, because when they come into my office, it's often tears, 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 tears. They're overwhelmed. They don't know what to do. They don't know how to navigate the system. They're full of guilt and full of shame. There's so much going on inside of them, and then they don't know what medication their family members are on. They don't know when they first come into. They don't know anything about what the treatment plan is. They don't know how to support them when they go home because of the confidentiality. And I understand. I'm not trying to put down confidentiality. There's a reason for it. And yet, when Peter keeps on saying that it's kind of like a cloak that's prevented him from being able to be the best support that he could for Connor. So coming and seeing I am the family worker within the early psychosis program, and so we're able to strategize and talk about different ways of coping and liaise with the other clinicians within our program, so that I can, without breaching confidentiality, give him the information that he needs to be able to support his son in the way that's most helpful. So family support in the ER, I think, would be critical to the well-being of our patients, because they can't do it on their own. The families are not professional, and they're often so overwhelmed, and it's out of their scope of practice to be able to think that they would be able to take this person home from ER and be able to manage when the person especially is in a psychotic state and or whatever mental health condition that they're suffering with, addictions and mental health or psychosis. We have a lot of our patients that comorbidity, what that word is very, very prominent within our population. So I think, Peter, the thing that was struck me that I think I would love for you to share with our audience here today, Peter, is that you had some recommendations as to how in the emergency department itself, how that might, in terms of the rooms and of the interaction that you had with the clinicians there, the doctors and the nurses. So, would you like to speak to that?
Well, on the I don't know what you call it, emergency department, the triage department, when you come in with the ambulance, and the rooms are all, they're there to save lives. They're there to have heart attacks and stuff, and not overdoses, I guess. But no, it was very, very professional. Very okay. Next one, you can go home now. You're with your dad. But what was missing was maybe a little more discussion, a little more taking the name and somebody call you in a few days, a follow-up. Because somebody in there with an overdose, I'm sorry, but there's mental health issues happening here too. People just don't go around doing that without some issues. And when you peel away my son's issues, it's all mental health under there, anxiety, depression, just a mixed bag of stuff. Of course, you put the addictions on top of it, and it's just, whew, good luck, right? So that's one side. Other than that, the other side is the physical, the inpatient side where we walked in. It was length of time, and look, it is what it is in our healthcare system. But again, with someone with mental health and agitation, there needs to be a little more, that 20-second coming out to a parent or loved one saying everything's cool, you just hang in there for another hour or something. And then the physical issue of the room is atrocious. It's somebody like that should be in a soft room, maybe some light. A room that's not scary is absolutely frightening to my son, and it was irritating to myself. It's a scary room. It's hard, it's ugly, it's mean. It's prison-like. And you just don't put somebody with a mental health agitated state in a room like that and leave them. So other than that, everybody's been fabulous. Fabulous groups. Can't say enough about the people that we've had help from. It's just amazing, really. Thank you.
Okay. I think what we could probably move on to now is some questions from the audience, because Peter has summarized his experience with the ER being one where the professionals that he interacted with were very, very good. The cosmetic aspect of it could be improved. And then he moved on to the early psychosis program where he is today, where Connor is today, and continues to get the support that he needs. So I'm wondering if there's any questions within the audience that you might have for Peter in his experience with the ER mental health.
Can you hear? Is this on? Okay. First of all, Peter, I'd like to say thanks very much for spending time with us this afternoon. I think we hear so much about medication and a lot of the research that's going on, but I think very much of what we do day to day, the great influence comes from the people that we care for, and the family members of our patients are absolutely the people that we care for as well. I don't have a question, I just have a comment, and it is about those rooms. The rooms are atrocious. I work in the emergency department, so I speak from experience. They very much feel like you're in the bottom of a boat. When we planned the rooms, we had absolutely envisioned a room with soft lighting that was comforting, that provided someone with a sense of security. However, being part of a large institution, some forces bigger than us took over, and we ended up with things in the room that weren't things that we had hoped for.
No, and I appreciate that.
Yeah, and some of it, they're just things like having the chairs attached to the floor. I hate that. The staff hate that. However, it is part of the standards to provide safe care to people in emergency departments. However, we've done a bunch of things to try to make the rooms a little bit better. We haven't had great success, but if there are any things, any practical solutions that you could bring forward that you think might make those rooms a little bit better that we could actually do and implement, please bring them forward. We're always, when you're in the emergency department day after day after day, you kind of forget. It's like having a great big chunk out of your wall at home. If you walk by it every day, eventually you stop noticing the chunk in the wall. Yeah. So I think that could be possibly where we are now. So if there are any solutions or ideas that you have specifically in order to make those rooms more comfortable and less frightening, because you're absolutely right. When we have a young person in that room that's possibly having their first contact with mental health, the last thing we want to do is to make their experience worse and to make them even more frightened. So please, thank you very much for spending time with us today. And if you have any, through Trish, bring those ideas forward.
Yeah. Okay. My pleasure.
Thanks.
Thank you. Okay. Oh, there's another question.
I also would like to thank you for sharing your experiences. I think it's very valuable. I work with children and adolescents where very much family is very much part of what we do. And the issue of confidentiality is less an issue, especially when we're working with children. With teenagers, of course, we would generally be speaking with the teenager about, is there anything you don't want us to share or discuss with your parents? Because we're going to need to meet, because they're going to have to figure out what's going on. So it's certainly an issue that we need to respect in our business. Confidentiality is important for the care of the patients, and perhaps I run across it less clearly because I'm always working with children and adolescents, or meeting with parents where we can talk about the situation, even if not some of the specifics. However, you've clearly had some difficult experiences with it, yet something seems to have worked for you now in the early psychosis clinic, and the confidentiality didn't seem to interfere. I'd be interested in understanding what changed, what was the difference, and what recommendations you might make about confidentiality and care and working with parents.
Well, I've talked to some other parents. We'll talk about the psychosis department. There was comments made maybe between a nurse and physician. There's these communication walls, even within your own business, of perhaps a layer of power, and that exists with a parent that's scared or not comfortable to challenge a doctor, not even comfortable to ask if they can attend, and it's a hard subject to approach by some parents. I particularly didn't really have a hard time. I just asked, but it's depends on how you grew up. Let's face it, doctors are God, aren't they? So what really helps, I guess, we were in a education group, and I think one of the other parents asked, "We don't know what's going on with our son. We don't, we're on the outside looking in," and it came up, well, you can go in with the doctor. Oh, really? Didn't know that. And you can actually talk to them and even email them or go through somebody. But it's not readily apparent to a lot of people that access is there. You may think it's there, right? But we don't know that. And it's certainly not broadcasted, almost as if it's not even encouraged. Now, I'm not saying that about the psychosis department, because once we got over that hurdle, that was perhaps a misunderstanding by the parents. So then, once we did engage, or I engaged, we had very good back and forth by email, or I mean, the doctor would not respond. What I was really doing is giving him my observations from home over the past 2 weeks. So I was sort of his eyes, I guess, in the field, and but I certainly never would have thought about that for the first month or so at the psychosis, and then eventually I got invited in to the sessions at the last 5 minutes. Eventually I got in for a whole session. And of course that depends on your patient. I mean, he was of the age that, he was over 19 then, or 19, so he can certainly know, no, he's not coming in. And that's every right. But it's getting over those hurdles of a parent does have a right, or a loved one does have a right to ask and try to engage. But it's up to the parent to scratch that surface to find out. And of course, some parents are aggressive and they'll do it, and others, oh, okay, the doctor knows best. That's a society issue anyway. I mean, let's face it. Interesting enough, on the side note of collaboration, I'm working on I'm in the construction business, so we're building the collaborative health education building at Dow. And I'm construction manager, so there's a floor there that the doctors, nurses, OT, physio, and a few others are trying to put a governance process together and actually work all together, actually train students and work. And what's been interesting for me is how hard it has been to get the departments to work together. 2 years, and the light sort of finally went on with the group. Oh, yeah, we don't need all those beds. We can share beds. They're actually finally working together. It was so foreign to me because I'm in the construction world. That's how you do things. You just work together. It doesn't matter if you have a degree or you got grade 6. You got to get this thing built. So I was caught off guard with that, and it's been an interesting eye-opener for the industry of trying to, because my job is to try to find out what you all need in the walls and the beds and everything, and trying to get you all to work together. It's been almost impossible. So anyway, we're making headway. So, and on a positive note, at the end, my family's a lot healthier now, way healthier with the help we've found and been offered, and my son's a lot healthier. He's on the road to recovery. I was going to tease Dr. Zed because I think Connor's been reading his articles about drug adverse because he refuses to take his medications. But it was very frustrating for me for the last 3 years. He wouldn't take his meds to try to get better. But so I come around. Maybe he's right. He's been off all his medical stuff, and he's working on his other addictions, and he's healthier. So who am I? It's working, whatever's working right now. So anyway, yep.
I just wanted to say thank you for sharing your story.
Oh, thank you.
And I am a family member as well. I have a loved one who lives with schizophrenia, and we live in a rural area, so it's a different set of circumstances. And you talk about a box. Well, we don't have a box yet, but they are going to build a new ER, so we're hoping that they will have a box, but we'll have some say in what the box looks like, I hope. But like yourself, when my son was first diagnosed, I had no idea what we were going through. And to arrive in the ER with someone who is clearly psychotic and very, very ill, and then all of a sudden you see the handcuffs and you see the leg chains. Anyway, it's very heartbreaking.
It's tough.
Anyway, yeah, it's very tough. So, and then, like yourself, they are hospitalized, and then they leave the hospital, and it's see you later. He said, I have this bottle of pills, but I don't know what I'm taking it for. I have to take them, but I don't know what I have because I'm not sick. There's nothing wrong with me. So anyway, I spent 7 years with him. I put him through my own rehabilitation program that I designed myself.
Yeah, I have one too.
And I had to educate myself. Yeah. I went through every hurdle from the university. I tutored him to St. FX. I did whatever had to be done to get his life back on track, because what we were offered was an apartment with the Department of Community Services out somewhere, and some benefits from them. I said, he's 20 years old. He's brilliant. He doesn't need to live with an illness, live with the side effects of the medication, and then you're subjecting him to a life of poverty and isolation, and he's 20, and that's it. So that was not acceptable. So I worked with him. It took 7 years. It's a long process. He did get his degree from St. FX, and then he got very well, and he went back to the community college, and he did a diploma in business. And this is a young man who has what we call disorganized schizophrenia with very, very severe cognitive. And he was the only one in that program that got an honors diploma. He has been working full-time. Yeah, he's working full-time with a major bank, and he's been there for the last 7 years, and he's doing excellent. So as a family member now, I educate. I co-facilitate a family support group. I work with the Families Matters education program, and I promote everything family I can, and also try to reduce some of the stigma. And if someone asks you, are you ashamed of this? I said, no, it's a medical condition. He didn't wake up one morning and said, I think I'll have schizophrenia today. I have nothing else to do. So it's not his fault, and he knows that, and he lives very well with it. He said the only thing that bothers him now is not the illness, it's what people think of it.
Yeah. Well, humor's a wonderful medication, isn't it?
Yeah. And he's just such a, like your son, very, very wonderful young man, just happened to be ill, and it changes their whole personality while they're ill. Yeah. And anybody who has family members here, I'll tell you, when they start attacking you, remember, it's the illness, it's not the person.
Yeah. So this is where we're heading with our son, where you are now. So our son will be 22 in June, and he's starting a job in another week, full-time job. So it's coming. It's a long, hard road, but it's coming.
But we support them, we give them hope, and we give other people hope.
Yeah. Thank you. Thank you for sharing that. As a family worker, I think I have the most privileged role of all, and I commend parents greatly for all the work that you do. What I notice is that when parents are involved in the care of the recovery plan of the patient, of their family member, they progress a lot smoother, faster. They achieve a lot of their goals. We have lots of successes in our program of people who live with schizophrenia who've gone back to school and have achieved great and wonderful things. And that structure, that support is vital to their care. I don't, sometimes you think that, or you'll hear sometimes that we don't deal with families because they're difficult, and I think, well, it's not the families that are difficult, it's the situations that are difficult. And it's really, really important I think if we keep on talking about money and saving money, there's no greater saving than to educate, support, and be there for the family members, because 99.9% of the care is done by family. So why wouldn't we give you everything that we can give you to do your job well? So thank you.